Well, welcome everybody. My name's Simon Billings from the Academy of Chiropractic Nutrition. This presentation is about vitamin B12, an epidemic of misdiagnosis and misdiagnosis. Vitamin B12 is a complicated and challenging topic to teach because of the wide variety of symptoms that deficiency can present with, and in particular because the diagnosis of vitamin B12, there is no reliable marker to definitively rule out B12 deficiency. You can rule deficiency in with the blood test, but you can't definitively rule it out. And so for that reason, it can be somewhat complex to do in half an hour. But what we've done is created an overview to try and give you a broad picture so you've got something to use on Monday morning. So let's just take you through the main areas here of B12. We can see that the B12 holds two key rate-limiting steps within your metabolism. It's a cofactor for a rate-limiting enzyme in a process known as methylation. Now we'll go over that in a moment, but that involves the production, for example, of myelin, which is obviously extremely important, but particularly from our point of view, from a point of view of pain, as well as tingling and numbness and neuromechanical symptoms presenting to a chiropractor. It also is involved in the production of new DNA, which can affect the production of new cells, obviously, and that may then have an influence over your ability to produce and maintain connective tissue. In a separate area, it also is a cofactor for a rate-limiting enzyme in the Krebs cycle. So it is intimately involved in the production of energy independent of anemia in that particular case. Now then, the key symptoms for vitamin B12 deficiency, they commonly will turn up with persistent pain, and that's very important. It's persistent, pins and needles, and numbness. Now, if it's bilateral, it's a bit more obvious that there's probably not mechanical, once you've ruled out some kind of central issue in terms of myelopathy, from a structural cause at least. But if it's unilateral, often you'll find that they have existing neuromechanical issues, and that as their myelin begins to disappear, their pain threshold will tend to drop down, and this will then highlight or exaggerate existing issues or a latent neuromechanical defect, and that can be much more challenging to pick, simply because they'll turn up and look like a standard neuromechanical case. Because of the ability of methylation to affect new cells, they may well present incidentally with mouth ulcers and glossitis. So if they complain of a sore tongue or a burning mouth syndrome, the turnover of the cells in the mouth and indeed the digestive tract is extremely fast, 3 to 5 days, and you have a completely new lining. It may well be that they can't keep up with cellular demands to make new cells, and that's the canary in the coal mine in terms of cell production, and the mouth is your window to see exactly what's happening on a cellular level in terms of production. Mood and behavior will frequently be affected, or depression and anxiety. Now that's partly because of the methylation effect on neurotransmitters can be very, very important in the way they're produced. But also when your methylation goes down, often your inflammation levels go up, and inflammation is intimately related to any form of depression and anxiety through changes, once again, in the neurotransmitter production. Anemia, this is usually, but not always, in the absence of anemia. It was a very early stage feature of B12 deficiency, but it's hard to define because people will tend to rationalize and justify why they feel a certain way, and it comes on very slowly, and therefore it's difficult to kind of pick up directly. It's one of the things also that as you lose energy, you tend to lose motivation, and that will be misdiagnosed then as depression. Note also that in the terms of anemia, because we now fortify many foods with folic acid, that extra folic acid will cover up a B12 deficiency anemia, and that's something to consider, and that's reflected within the guidelines. When it comes to testing, we really have it's tricky really because there isn't a definitive way to rule out deficiency. So indirect testing through anemia screening is unreliable. We just discussed that. Then when you directly test B12 within the blood, we can say that it's unreliable simply because there is no definitive cutoff points of when to define when is something deficient and when is not. There's a very large grey zone that exists in which patients may still be suffering from a cellular deficiency, and the blood will look reasonable but not great. And so therefore we'll say that the clinical picture is without doubt the most important factor in assessing the significance of a test result, because there simply is no gold standard of testing, and that's again reflected within the guidelines, certainly in the UK, that the assessing the clinical picture is the most important, because in the presence of strong symptoms, if you miss it, that can be a permanent neurological impairment that will develop. So if you have strong clinical features, if the test is in that grey zone or you're still very, very suspicious, you should implement B12 treatment to avoid permanent neurological impairment. You can test on a cellular level homocysteine. That's a reflection of methylation. It's a valid and reliable marker, but it is not specific to B12. It can be caused by low folate or vitamin B6. You can also use methylmalonic acid. That is specific to B12, and that's the intermediary which gets produced within the Krebs cycle when B12 is low. But its defining point of where deficiency begins and ends again is not clear, and so again it can't be used 100% to rule it out. The causes of low B12, well, if you're not eating it, then you simply can't absorb it. There's nothing to absorb. So if you're a vegan or vegetarian, then they have a higher chance of being low. Also, if you just eat a very poor diet with very high levels of processed food, then you simply won't have any B12 to absorb either. I haven't seen any difference between various demographic groups in terms of deficiency rates. There's no difference there in my clinic. It may be that if they are eating it, they're simply not absorbing it. If they have a named inflammatory bowel disease like Crohn's disease, or they might have celiac disease, more appropriately called gluten sensitivity with enteropathy. But they may also have something like IBS, which is a very poor term, but we know that on a cellular level, IBS patients frequently have inflammation and it can affect their ability to absorb. SIBO is an acronym for small intestinal bacterial overgrowth, which often is the real cause of IBS and is known to reduce absorption. Certain infections like Helicobacter pylori will lower down stomach acid, and Giardia will compete with absorption in the small intestine. Medications such as proton pump inhibitors, they lower stomach acid so profoundly they inhibit the ability to release B12 from the food, and metformin will block the ability of B12 to be absorbed in the small intestine. And also we have autoimmunity against the stomach lining, so you produce less stomach acid and less intrinsic factor. That has been historically known as pernicious anemia. It's a very poor term, because it implies they have anemia, which often they don't. And when they do get anemia, it's a very, very late stage feature. The treatment that will be delivered, we're going to use sublingual, between the cheek and the gum, or liposomal B12. These are the absorbable forms. If you give a swallow tablet, because they usually have issues with absorption, they frequently don't get the response that you would hope for. Not always, but in order to cover yourself for any malabsorption issues, sublingual or liposomal will work very well. I always recommend giving the active forms of B12. We'll cover that in the presentation in more detail. That's methylcobalamin or adenosylcobalamin. Between 1 and 5,000 micrograms, depending on the sensitivity of the patient, and if they have a predominant pain and fatigue, I'll push the doses up higher initially. If they're more sensitive, I'll drop them down a little bit to 1 or 2,000. And I always pair it up with a methylating B complex that includes methylfolate, vitamin B6, B2, and trimethylglycine, because methylation involves all of those nutrients. And so if you just give B12 and they're not only not absorbing B12 but also they're low in B12 and folate, you won't see a clinical change because they're low in other things as well. So it's best to cover your bases. The only exception to the rule is if the patient has a current or historical history of severe anxiety, in which case avoid using the active forms of B12 and use the inactive form known as hydroxycobalamin. That's the form used in injections generally. Use that on its own and don't use the methylating B vitamins initially. Just let them feed in nice and gently to start with. So let's now add a little bit of meat to the bones that we just outlined there. We'll talk about methylation. It's really a process of making stuff or activating things or breaking stuff down and deactivating things. So the making things, we can say it makes myelin, which is very important obviously, and DNA and RNA, which is involved in the repair and maintenance of our cells and of course making new cells. It also is involved in 40% of methylation goes to making creatine and phosphatidylcholine to make your cell membranes. And then for the deactivation and breakdown, it breaks down a whole load of different neurotransmitters. That's very important. If you're low in methylation, you break these down poorly. It can very much predispose and drive mental health issues. And also it is involved in the turning on of certain neurotransmitters and the conversion of serotonin to melatonin, so it can be involved in insomnia as well. If you don't get enough methylation occurring because you're low in B12 or B6 folate, B2 or trimethylglycine, then as this goes down and you make less myelin, less DNA, or so on, you will get an increase in an intermediary known as homocysteine. This is extremely toxic, very, very inflammatory. It also is a direct trigger for increased firing within the central nervous system. So if you have a source of nociception, then it will increase the firing, it will increase your pain levels. And that's very well studied within things like fibromyalgia as well. So it's a very, very important process. It's critical for maintaining yourself, but also when it goes wrong, you'll build up levels of a very toxic intermediary as well. So let's take a look at a rough idea of what it is. It's really a process of recycling. So we take protein in, we come down, we do what we need to do to make our things or break things down. It spins round. As long as we have enough B6, B12, and the active form of folate, known as methylfolate, then it spins round in a constant cycle. So let's now add in the actual details. The amino acid from protein is methionine, hands over its methyl group and does the business. That makes homocysteine. If you have enough B6, you can come down this pathway into glutathione or sulfate. Sulfate is very important for the joints. Think glucosamine sulfate. We actually make our own. Or you can use B12 and folate and recycle back up to methionine, and that pathway spins and spins and spins. You can see here I've added on the folate cycle. This one comes down. This is where you get folic acid from supplements. That's dietary folates coming down the line. You get the active methyl group here, and that's what B12 hands over to recycle. It's a constant spinning thing. You get DNA replication over here as well. And that's partly where anemia comes from with folic acid. So you can see it's extremely important fact. It's happening thousands and thousands and thousands of times a second. It's a critically important part of your basic metabolism. And B12 holds this unique bottleneck position where it really can be a rate limiting factor in the entire process. When it comes to making energy, we know that you take your fat, your carbs, your proteins, they come down and they enter the citric acid cycle or Krebs cycle, spins around at the very bottom here, electron transport chain, you make ATP, you make energy. There's one step here and you need to feed this, it's succinyl-CoA, and you take MM-CoA, methylmalonate-CoA, and you step over and it becomes succinyl, and that feeds that pathway one step straight before it drops down. That process again is 100% B12 dependent, that enzyme. If you don't have enough, then you get a spilling out into the urine of methylmalonic acid. That's a valid mark of a B12 deficiency, and without that feeding here, you can have a perfect Krebs cycle with every B vitamin you need, every mineral you need, every amino acid you need. But if B12 is down, your entire citric acid cycle will slow down. They will get fatigued, and that will be independent of anemia. So when it comes to pain, probably through the link with myelin and also with homocysteine, there's some very low-hanging fruit here for us as neuromechanical practitioners. Most of us having some kind of pain-based symptom coming in as predominant symptoms that we look at. Now, these are patients with chronic non-specific low back pain, and they didn't test B12 levels at all. They gave everyone 0.5 milligrams, that's 500 micrograms of the active form 3 times a week for 2 weeks. It's quite a modest dose that I certainly give far high doses clinic. I can give up to 5 milligrams every day for the first month if needed. And you can see after 2 weeks, they have a 32% drop in pain. Very easy thing to do for someone that clearly has persistent pain. And you can add that into your neuromechanical care. As I said, very, very easy to do, extremely well tolerated. They also tend to get more energy as well, which then allows them to adopt often healthier lifestyles and so on as well. So physical manifestations, keep a close eye on the mouth. As I said, it's a window into your cellular machinery. You can see here the tongue, very sore red spots, and up on the top here as well. And then after B12 supplementation, you can see that they've managed to then turn over that cells, become far, far greater, and they're making healthy pink tissue. I would ask you to consider the gut lining. If his tongue is like this, what is his gut lining going to be like? It's commonly where people then have deficiencies from low B12, and then the low B12 means you can't make the gut lining, and you get even more deficiencies, and you end up in a very vicious cycle. And then if you look for mouth ulcers as well, exactly the same principle. And also cracks the corner of mouth can be a sign that they're less common. And there's some research here backing up use of B12 sublingual dose there in the treatment of mouth ulcers as well. If you have any patients with higher melanin content, then please check their hands and feet typically along the joint line of the hands and feet, the dorsum. You'll see a hyperpigmentation occurring, and you can see also on the palms. You can see here before very dark, and then after much greater change in the pigmentation there. So fatigue independent of anemia, we saw that Krebs cycle adds that one step that's B12 dependent. So as your B12 levels begin to drop, they'll very gently begin to get fatigued, and just be aware of justification and normalization and rationalization. It's very easy to justify why you feel some way. You have no frame of reference. Energy is a spectrum. I frequently find that when you have less energy, they've got less motivation, that'll be misdiagnosed as depression. Keep an eye out for that. As I said, anemia is a very late stage feature and is often absent because of the issues we'll talk about in a few slides to do with folic acid within the food chain. So fatigue via anemia, if that does occur, you'll get enlargement of the cell. That's a macrocytic or a megaloblastic anemia. That's the MCV as mean cell volume. That simply means they're going to have less oxygen being carried, and that means within the mitochondria, you're going to have less efficient energy production. But it says a very late stage feature, and it simply does not rule out B12 deficiency if they're not anemic, and that's reflected certainly within the UK guidelines very clearly. And you can see here, this is a patient that I consult one-to-one with online purely for her chronic fatigue syndrome. She was exhausted, barely able to function. Hemoglobin MCV within normal range, B12 well below reference range. Reference range is 160 and below usually. At 121, clearly deficient. But the GP refused to follow guidelines and give B12 injections. But luckily, with the supplementation we'll talk about, she's able to live a normal life once again. So we know that we are now fortifying the food with folic acid, and it's been very successful in terms of neural tube defects, and that's probably actually through methylation potentially. But you can see here that they found that patients with low B12 were likely to be that without the anemia, more likely after fortification, and therefore maybe the fortification actually has led to the covering up of B12 deficiency if you're using anemia as a way of screening for B12 deficiency. And that then, once again, is reflected within the guidelines. You simply cannot use the absence of raised MCV and anemia to exclude the need for B12 testing because neurological impairment occurs, in cases where it is indeed low. So ultimately, the guidelines reflect everything that I've said because they're based on the research, obviously. They're quite clear about the clinical picture is the most important factor in assessing the significance of a test result for B12 status because there is no gold standard to define deficiency. If you take nothing away from this, please understand this, that the clinical picture, if they have symptoms that are suggestive of it, what are your symptoms? You really be very careful in dismissing that. The B12 test is not a good indicator of the patient's status. It's very unreliable. Definitive cutoff points simply are not possible to define clinical and subclinical states. So there's a grey zone we'll talk about in a moment. And if you have a discordance between the test result and strong clinical features, particularly neurological ones, you must avoid delaying treatment because the neurological impairment, that can be permanent. You get demyelination, that is a permanent thing. So if in doubt, you should give a trial of B12. It's 100% non-toxic. It's completely safe. It's very cheap. We don't want patients coming back in and then complaining about what's happened to them because we've been neglectful. And I say this is simply a reflection of what is in the guidelines, certainly in the UK, and that's usually reflected across the world. So the reference ranges here in picomoles in the UK. Anything under 160 is generally defined as deficient. Above 160 will simply be returned as adequate or normal, but we have a real issue with that because this is the total B12, and within that there's going to be an active fraction and an inactive fraction. The active fraction is available and will go into the cell, but that can be as little as 10 to 30% of the total B12 in circulation. The inactive fraction is bound to a different carrier. You cannot get it into the cell, and that of course represents a real problem for us trying to interpret the total B12 levels. So along the bottom axis, this is total B12, and on the vertical axis, the active B12 fraction split away. So 160 is marked as is 300. To the left there, anything under 160, these are deficient. anything above there, the NHS is going to say that these are completely normal and there's nothing wrong with their B12 levels whatsoever. So what we want to do, therefore, is add in the active part and see where that leaves us. Now, we should also say at the beginning that the active fraction, again, where deficiency, insufficiency, optimal, where that begins ends, we just have no idea for sure. So I've seen it as low as 35, I've seen it as high as 70, being the point where you would below there, you would cut it off. If we take 35 at a conservative estimate, anything with the green triangle here and the turquoise crosses, all of a sudden, all of these people are going to be needing injections or some kind of B12 therapy. All of their neurological symptoms, their mental health issues, their pain could be potentially because of poor methylation and poor mitochondrial function. If we take a higher level at 70, which is reported in some of the research, you have got a huge number of people that are being reported as normal now getting needing B12 injections and therapy. And you can see here, even in the 200s, the 300s, even above into the 400s here, you can see that these people, some of them still require therapy potentially. That's why anything under 500, generally, I'm going to say you should treat. So we consider 160 to 500 a gray zone. You need to combine the symptoms, look at the symptoms, and then interpret the test accordingly. If they're anywhere in that gray zone and they have symptoms that fit, I would always advocate either further testing or you are within your rights to simply give B12 as a trial. This grey zone exists and we absolutely want to get them into an optimal. I personally like them above 800 to make sure that I'm getting the levels up high enough to really make a difference on that cellular level. So if you don't eat it, you can't absorb it. Vegetarian, vegan, junk food, you haven't got it. Vegans actually are frequently more likely to supplement because they're aware their diet's going to be low in it, or they're not absorbing it through a number of mechanisms. So they need stomach acid to break the B12 off the food. If you are over 70, frequently, or maybe even 60 in many patients, the stomach acid levels drop significantly. That can be a real issue. Helicobacter pylori actually reduces the stomach acid levels as part of its survival mechanism, and frequently Helicobacter pylori will end up with a prescription for omeprazole, a proton pump inhibitor. Anyone with weight loss surgery have had their stomach removed. And also we need intrinsic factor to be produced as well as stomach acid. If you have autoimmunity against your stomach lining, then you won't make this, and that's unfortunately historically known as pernicious anemia. It's badly named because they're not usually anemic, and that can be a real problem as well. Then if you do get it there, the B12 unbound from the food comes down into the small intestine, and it needs a healthy gut lining to be absorbed. If you have Crohn's disease, if you have celiac disease or gluten sensitivity without enteropathy, there can still be inflammation present and leaky gut. IBS, it's a bad term. Most of the IBS are actually gluten sensitive but undiagnosed, or they have small intestinal bacterial overgrowth. That's fairly well established for a lot of them. They'll often have bloating and constipation and gas and so on. And also the diabetes drug metformin will reduce the ability of your patients to absorb their B12, and that can be a real issue because if a diabetic patient turns up with tingling and numbness in their feet and pain, it's very easy to diagnose them with diabetic neuropathy. It's very reasonable unless you're aware that metformin slowly reduces down your ability to absorb, and the levels of B12 drop slowly and steadily down. This is a 4-year study. They could be getting symptoms anywhere along this line depending on how much active and inactive fraction B12 they have. So nerve and brain damage from this can be permanent. So if any doubt, always give B12. That's exactly what's in the guidelines in the UK. You must avoid any potential for permanent neurological impairment. So the forms of B12, cyanocobalamin and hydroxo are inactive. Cyanocobalamin we don't need to use anymore. It's inactive, it's difficult to convert. I would use hydroxocobalamin if they have any form of anxiety currently or historically. It's inactive, but it's a direct precursor to methylcobalamin and adenosylcobalamin. So methylcobalamin works directly within the methylation cycle. Adenosine works only within the mitochondria. So I prefer these two because they immediately work. Some patients have an issue converting hydroxy into the active forms potentially. So that way you can avoid it by getting them straight in here. But if they have any history of mental health, strong into mental health, I tend to give hydroxocobalamin just to be safe because the sudden increase in methylation, the sudden production of neurotransmitters and conversion can be somewhat shocking. So generally you give sublingual forms work very nicely. Methyl and adenosine, 1 to 5,000 micrograms, that's 1 to 5 milligrams. If they're sensitive, I'll lower the dose down to maybe 1,000 or 2. If they're pain and fatigue predominant, and I think they can take it, I'll crank it up to 5,000. I do that daily, I do it for a month, and then I will reassess their symptoms. And you can also use liposomal. I found that to be as good as an injection. I had a couple of patients who were self-injecting, and they no longer need to. They're using the liposomal. It goes straight in, very, very easy, and it can work really, really well. That always pair it up with methylating B vitamins, because you need B12 and methylfolate and B6, and also B2 affects the enzyme over here, this enzyme here, and trimethylglycine gives you an alternative way of removing homocysteine. So if you're low in B12 because of absorption issues, you might also be low in folate or B6 or B2 or anything else. So if you miss one of these out, you won't get the wheels to spin, and therefore you'll miss the beneficial effect by adding in B12, and it still won't myelinate. So I tend to cover my bases by adding in a methylating B vitamin. It will usually have ingredients like this. It will have B6, active folate. Unfortunately, because many of your patients will have issues with absorption, they won't absorb the B12 in the swallowed tablet very well often. That's why I pair it up with a sublingual to make sure I get it in the system. But it should look something like that. There's lots of them around. They'll usually be called something like methyl factors or homocysteine redux or something of that sort. So that brings us to the end of the presentation. Let's just take one more look at the overall guide to the B12 issues. So we know that it's a cofactor for the rate-limiting enzyme in methylation, as well as a rate-limiting step in the Krebs cycle. Key symptoms are persistent pain, pins and needles, numbness, tingling, and so on. Bilateral is usually pretty obvious. Unilateral is slightly harder to pick. We can use the mouth as a guide, potentially to the cellular turnover and ability to make new cells. Depression, along with anxiety, are very, very common features. Fatigue is very common, usually in the absence of anemia. When it comes to testing, we know there really isn't a definitive way to rule it out completely. You can rule it in with a low test, but a test between 160 and 500 really doesn't rule it out. If they have symptoms, I would always encourage you to either do some further testing with homocysteine and methylmalonic acid, or simply go for a trial B12 period of a month. Remember, if you're going to do a trial period of therapy, you ideally would use the active forms combined with a methylating B vitamin as well. So make sure that you have all the nutrients in there to make sure the methylation cycle spins properly. Also consider those medications. I find that a very common cause. Metformin, I've seen a number of people diagnosed with diabetic neuropathy. Consider that, and the proton pump inhibitors seem innocuous, but actually can really deplete the system of key nutrients. And remember also that IBS is not innocuous. It's not, in the vast majority of people, some kind of psychological based disorder. It's very much in the gut with issues in terms of inflammation there from a variety of issues, but certainly a small intestinal bacterial overgrowth is indeed a common one. So I hope you found that useful. Once you start looking for these kinds of symptoms where they have persistent problems, when they've seen other practitioners first, not had a result, when they've had treatment for mental health issues, not done very well with it, you'll start to see them everywhere, and have a good look at the family history, because often they'll have a long family history of persistent problems like that as well. So once you start seeing them, you won't be able to stop, because in fact it's very, very common. The deficiency rates are actually pretty high once you start looking at it on a cellular level at least. If you have any further questions or would like to get hold of me, you can go to my website, www.academyofchiropracticnutrition.com, or you can email me on simon@integrativecare.co.uk.